And the triage nurse finds that the pulse rate is 260, and pulse oximeters, as you see, is 100. She put him on rhesus, and the child looks pink, well, and stable, and that the monitor looks like, that's what your monitor looks like approximately. And this would be probably your ECG, the 12 leads ECG. So what is the best management strategy? If you can scan the QR code and participate in the quiz.
Marwa, maybe leave the QR code up just for a tiny bit longer, just in case people are getting their scanner out.
Okay.
Yeah, perfect. We're going to give everyone like a couple of minutes to have a think about what's gone on, have a vote on the thing, and then we'll put up the results and we can move on. So maybe by 12 past, Marwa, we can switch to what the results are.
Yes. Is the QR code working? If there is any problem?
It's working.
Okay. Yes. So as you are all answered the correct answer, Valsalva maneuver or diving reflex. So the objective of our talk, my talk today, is to define the SVT, and as it is not clear for everyone, the SVT definition, and to remind all of us of boring electrophysiology that might help us to understand how to go through this, and also, I will speak about the types of SVT and the presentation in different age groups, 5 outcomes of adenosine, and things to think about when adenosine fails, plus how you manage if you are not anticipating them. What I call it 5Ds, and with the different clinical scenario based on true cases. So the definition of SVT. So generally speaking, SVT, supraventricular tachycardia, is a narrow complex re-entry tachycardia, but actively it means arrhythmia originating at or above the AV node, and it includes every other thing like sinus tachycardia, AV nodal re-entrant tachycardia, AV node, AV re-entrant tachycardia, AVRT, and atrial tachycardia, atrial flutter, junctional tachycardia, atrial fibrillation, and multifocal atrial tachycardia. So, but initially, what we want to speak about is the paroxysmal supraventricular tachycardia, which include the AV nodal re-entrant tachycardia and AV re-entrant tachycardia, atrioventricular re-entrant tachycardia, and atrial tachycardia. So 3 types of paroxysmal supraventricular tachycardia. The first type, as we said before, the AV reentrant tachycardia, common in infants, and this is 80% of if infants had AVRT, and this would include accessory pathway, and that bypass the normal conjunction, and this include also WBW with bundle of Kent is a classic example, as here. And ectopic atrial tachycardia, and ectopic focused outpaces the SA node. So here is the SA node, and maybe there is an ectopic atrial tachycardia is going here and causing the circuit. And the third type is the AV nodal or atrioventricular nodal or junctional tachycardia, and this common in adults, which is here the physiology of the conduction in the heart, in the normal heart. And just to say in short, that's a cyclical reentrant pattern due to dual AV node pathway. From the slow and fast conduction, and this type will create a circuit, and this difficult to treat usually occurs in setting of post-extensive atrial surgery or rapid firing of single focus in the AV node, slower rhythm 120 to 200. So the SVT in different age group. SVT in infants, this is very challenging as it's commonly have non-specific complaints as fussiness, poor feeding, not acting right. Typically the infant can typically tolerate the SVT for 24 hours. And those who with congenital heart disease may not tolerate it as long as the normal heart, the people with a normal heart, as they have lost the atrial kick and short diastole, which diminish their already poor cardiac output or function. Eventually, SVT will affect the heart adversely, even if it is normal, within 48 hours, and half of them will develop congestive heart failure. So the SVT in older children will not have the same complication and morbidity because primarily because they are able to describe their symptoms. So how to treat? First, we should the aim of treatment. The aim of treatment is to stop conduction through the AV node for long enough that the SA node will take over as primary pacemaker. And we can do this in ED, either physiological or medical. So the first thing we should try is the physiological reverse of the SVT. And this will happen with the Valsalva maneuver. This can be done using Valsalva in older children by blowing into a pipe with the patient, and we will show you the video after that. So blowing into a pipe or syringe, and this blowing into pipe attached to a sphygmometer to hit 40 millimeter mercury for sustained 15 seconds. Or patients who blow into a 10 mil syringe and aim to start moving the plunger. Both are effective, and this works with extra squeeze of the heart, and the pathophysiology will be working whereby the heart increase the cardiac output and increase the carotid, and parareceptor stimulus increase the blood pressure. In the initial stage when he blew or with the syringe or in on the tube. After the pressure is sustained, blood volume is forced into the legs and head, causing neck vein distension. The drop preload means the atrium is stimulated and the heart can pump harder and faster to make it up, and the blood pressure drops. At the end of the maneuver, there will be sudden release of all of the blood flow into the heart, causing huge flow of blood into the carotid and baroreceptor, leading to vagal inhibition. Using the modified Valsalva maneuver, and which is the new thing we will speak about today, is much better. If you lift the patient legs in the air and lie flat immediately after the release, and you will increase the venous return and improve the chance of reversion. So the Revert study, which I will show you today, showed the method of Revert in SVT is 43% more effective versus 17% in the standard Valsalva maneuver. And this study was done on the adult patients. So it's the Revert trial is RCT trial done here in UK, and it's exclude the patients with atrial fibrillation or flutter, or patient with systolic pressure below 90 millimeter mercury. And the modified, and it's just to compare the modified Valsalva maneuver versus standard semi-recombinant Valsalva maneuver. And it's worth to note that why we should try the modified Valsalva maneuver, because simply it has zero cost impact if you try it before trying the medication, and also there is no adverse effect, and it's showing 43% efficacy. So I hope the video will work. So after we saw the modified Valsalva maneuver, and it's worth to try it in older children while you are preparing the medication. And if you are treating physiologically or medically, it's important to make sure that you are recording a rhythm strip while you are trying to revert the ECG. The cardiologist will need to see this. So let's go back for the physiological reversion. Diving reflex is another version of this type. Young infant cannot do a Valsalva maneuver. although it can happen when they are crying. The diving reflex causes vasoconstriction, and the vasoconstriction, because it does in your heart, in your hand and feet and face, you have 110 times heat and cold receptors than the rest of your body. They act to protect you, and when you jump into cold water, you vasoconstrict to preserve the heat at your core. There is a massive shunt of the blood to your central circulation, and that your heart has to manage pumping into the lungs. And that causes you to take a deep breath when you are jumping to the water. When you put a baby in a cold environment, they get a profound vasoconstriction. In the same way, the blood is shunted to the core. You do, however, need a well-functioning heart for this to work. So all the blood that returns need to be pumped out effectively. And this potential problem only applies in adults with heart failure. In children with heart failure, studies show that there is a second pathway. As this goes through the facial stimulation of cold blood to the hypothalamus, and this causes the heart to slow down and decrease the metabolism. Because of this, children, even in heart failure, may still respond to the diving reflex, and whereas adults will not. You can use also the face mask here, and you submerge it in ice or cold water, which is put into the baby's face for 30 to 40 seconds. And this is effective as you are dunking them in a pocket of ice, but a lot more kind. Medical treatment. The medical treatment, adenosine, is our first line of treatment for SVT. It opens the potassium channels briefly to depolarize the AV node, aiming to break the circuit and for SA node to take over. This is the mechanism of action. It only has a half-life of 10 seconds, and we should remember that very well. We should start with a dose of 100 mic per kilo as the first dose, and then increase to the maximum of 500 mic per kilo less in units. I would like also to mention the side effects of adenosine you should be aware about, that sinus bradycardia, and the most common one is the long sinus pause after the reversion, which make you very stressed and causing autonomic disturbances like feeling of impending doom and this awful sensation. The older children can describe it for you. Hypotension, flushing, dyspnea, transient chest pain, bronchospasm. The studies showed also adenosine is responsible for the bronchospasm in some children. However, it's not a contraindicated in wheeze or asthma children. So the indication of adenosine, the main indication is to treat the paroxysmal SVT, to convert it to a sinus rhythm, and including those associated with accessory pathway and WBW. Also, the main indication is diagnostic to elucidate the mechanism of tachycardia and to reveal other atrial tachycardia covered under the SVT initially. For the absolute contraindication, you shouldn't use adenosine in this situation if the child has second or third degree AV block, or have sinus node disease like sick sinus syndrome or sympathetic bradycardia, or if he is known as with hypersensitivity to adenosine. Relative contraindication, you should be, it's rare, maybe you will not face it, but you should know about. SVT is common up to 50% in children after heart transplantation, according to the FLIER study in 2017. Adenosine often considered contraindicated in heart transplant patients due to parasympathetic denervation and increased sensitivity of SA and AV node. And the same study said that now to be safe to use the adenosine if we have to, but we should use it in much lower doses, like in 0.025 milligram per kilo and 1.5 milligram for above 60 kilo. It's worth also to know the interactions of adenosine, which will give you the understanding what is the dose and when to use adenosine effectively. So these the interactions with some common drugs in pediatrics. Interestingly, you can see that thiophelin or xanthine can antagonize the action of adenosine, and caffeine can diminish the therapeutic effect of adenosine. Carbamazepine may enhance the adverse and toxic effect of adenosine, and digoxin may enhance also the adverse or toxic effect of adenosine. Let's go back to our scenario again, and you administer 100 mic per kilo of adenosine and get the following step. What is your next step in management? Please scan the QR code and share what you think is the next management. Okay. Yes, exactly, correct. So reassess the vital signs. So this is the monitor after reversion. So the reversion is what we all hope for, where the patient returns to the sinus rhythm. And often there is a recovery tachycardia due to a net deoxygenation from being tachycardic for so long. All children with SVT, even if they revert, need cardiology follow-up. So the best management is also to refer for the pediatric consultant with cardiology expertise in your hospital, or to our tertiary is Royal Brompton, if you want him to have pediatric cardiology follow-up in special cases. So all children with SVT will need the cardiology follow-up. And this is to determine any underlying cause, as some will warranty an echo and or Holter monitoring, but also for prophylaxis. And children, particularly infants, cannot tell us why they are in why or when they are in SVT, and they may present after several days. And the late presentation will increase the morbidity. So the prophylaxis aims to prevent them presenting and collapse and failure in the future. And so the outcome also we will you should know about is that generally in infants are more likely to outgrow their SVT, and the studies showed that up to 70% of infants with SVT do not relapse when treatment was discontinued at the age of 1 year. And so there is also a recurrence rate. A recurrence rate is more with the age of more than 5 years at the time of the first episode. And the presence or absence of structural heart disease did not influence the outcome. The presence of WPW on the surface ECG did indicate a chance of a recurrent episode and even sudden death in symptomatic patients. So with the cardiology follow-up, there is 3 long-term treatment options we should know about. The first option is no treatment option. However, the no treatment option is not recommended in infants and in young children for the same beginning reason that it's very difficult to communicate with them, and we will never know when they will have the attack or the episode of SVT. Hence, stand the risk of heart failure and shock, and it may be suitable for older children who can recognize the problem early and attempt vagal maneuver to terminate this episode. However, we have also in our hospital a toddler who is in family monitoring with a device without any prophylactic medication. But yeah, so the first option is no treatment option. The long-term antiarrhythmic drug therapy. So digoxin is a traditional drug. There is a newer medicine than digoxin, but the most common is the digoxin as a traditional drug used to prevent SVT in children. Rarely deaths have been reported in patients who are on digoxin, and the patients with WBW, the best is to be on propranolol is recommended, and flecainide in resistant cases. Patients with myocardial dysfunction need amiodarone, and amiodarone therapy is a drug with a second line, should be planned very well in a consultation with pediatric cardiologist. The third option is the radiofrequency or ablation. The major advantage of this mode of therapy is you have a prospect of a cure, and the data of the ablation for accessory pathway in SVT has shown initial success up to 94% and freedom from the recurrence for 85%. In 75, 77, and 66 at 1, 2, and 3 years retrospectively. But the same studies also showed that performed only in a specialized center, the radiofrequency only in specialized center, and there is a major complication rate of 2.9% even in the best centers. Return back to our case. So we give the 100 mic per kilo, and then we give 200 mic per kilo, and there is no response. You are waiting and waiting, and there is no response, and you can see the monitor strip like this. Then we should think why there is no response. I'm sure it's happened to all of us. And when adenosine doesn't work, we should consider the 5 Ds. The 5 Ds include the delivery. So remember that only it has a 10-second half-life. So giving this, if you give it through the cannula, it should be in a large vein and with the arm up in the air, using the 3-way tap if the child is more than 10 kilos, and we will speak about this later, and ensure a fast bolus and flush straight after adenosine. So this is the first D, delivery. The second D is distance. Are you giving through the cannula in the arm or in the foot? And if you are using cannula further away from the heart, then a higher dose may be needed, as we need the adenosine to be active by the time reaches the heart. And the third D is the dose. So are you giving, are you starting at 100 mic per kilo? But actually the evidence shows that children need 170 to 200 mic per kilo to revert. So if you are using IO access or a cannula in the foot, then consider starting 200 mic per kilo. Drugs, as we mentioned before, the interaction, thiophelin, for example, competes with the adenosine receptors and antagonize its action. So if you have a child who have thiophelin, then you need to give a higher doses. And the last thing is the diagnosis. So the diagnosis, if you are giving adenosine multiple times and there is no response, it's worth to consider other diagnoses. So like fascicular VT will not respond to adenosine, as fascicular VT is when you have a smaller focus in bundle of hairs, and that it will act like a VT, but it's a circuit, and which will not respond to adenosine. And there is a rare syndrome also called long Ganong Levine syndrome, which is a pre-excitation syndrome of the heart, which I won't go into today, but it's basically when your atrial tachycardia bypass the AV node. So when you're doing a repeated doses of adenosine in the cubical fossa and the baby is not responding, so there is a probably alternative diagnosis to think about as well, and that all my 5 Ds. Return back to our case again. After 100 mic and 200 mic, what's the action after the following response? So there is a pause here, and after that it return back. So this will give us about a recurrent or re-triggering. So there is no response, and if there is any response, it's reoccur again. So sometimes we see a response to adenosine where the child returns to sinus rhythm but reverts within a minute or two. In this case, there is no point in simply continuing with repeated adenosine. And there is something triggering the SVT, and this what we need to be treated. So you should pay attention to possible reversible things like fever, asthma, pain, which make the SVT is re-triggering. Okay, and a second agent is likely needed here, and patient should be discussed with the cardiology. So the re-triggering SVT remind me with the refractory SVT. So refractory SVT that did not resolve with the first or second therapy, and this is super annoying. It occurs in 15% of all pediatric cases. Refractory SVT is seen with the greater frequency in infants, and especially infants that they were giving 100 mic per kilo as the first dose. So lower response rate may be due to, as we spoke about the 5Ds before, inadequate delivery or small GOG IV, and using the three-way stopcock method in children below 10 kilo. So we said in the delivery, we should use the three-way stopcock method in children. However, in children below 10 kilo, there is a study showed that it leads to lower than the intended dose of the delivery. And the studies are put it in the reference. Relatively resistance of infants to AV node to the adenosine, and infant presenting later in the course of illness, like they are more subtly or poor feeding. So that will lead to refractory SVT. So how to overcome this? Usually to start with higher initial dose, 200 mic as initial therapy have been advocated, and higher dose can reduce risk of unsuccessful cardioversion by 35% in both infants. The other treatment we should consider is sync cardioversion. The synchronized cardioversion should be used in the following conditions: if there is altered mental status, or there is a delay in giving adenosine anticipated with impaired perfusion or hypotension. It's worth to note that it has been documented reluctance for providers to use electric cardioversion in children, according to Lewis in 2017. 11 of 13 patients who had unstable SVT were treated without electric cardioversion. And in 10 years of study, synchronized cardioversion was performed only in 3 patients and only once while in ED. So everyone is reluctant to use this safe therapy. So as we mentioned that children generally tolerate SVT for prolonged time, but can lead to morbidity. The recommended dose of sync cardioversion is 0.5 joule per kilo to 2 joule per kilo. And it's also recommended to put the pediatric pedals when you are trying to treat a patient with SVT in case he deteriorates and he needs sync cardioversion. It's worth to mention that children more than 10 kilo require adult-sized paddles. Second-line agent for refractory or recurrent pediatric SVT. It was found that prokinamide is a new medicine or new drug, has been shown to be more effective than amiodarone. Amiodarone may not be as effective as commonly believed, and prokinamide 15 milligram per kilo IV for over 30 to 60 minutes. But don't forget, sync cardioversion or electricity is always an option too. So the key message: adenosine is a great drug, but it's imperfect. Go back, since adenosine has such a short half-life. Large dose give benefit and better efficacy with little added risk. Avoid refractory by starting with 200 mic per kilo, and that will make your life and the kids a little easier. Anticipate refractory, especially for the children who are under 1 year, and know what is your next steps with the second line and the sync cardioversion if needed. Use electricity for SVT and altered mental status. While kids cannot tolerate SVT well, you cannot tolerate poor perfusion in your patient's brain. If we return back to our case scenario, so we gave 100 mic per kilo and 200 mic per kilo, and we have this strep. So what are the following? What are the action after the following response? I want to mention the vitals. The blood pressure is 60/40, heart rate 180, respiratory rate 24, and oxygen is 100%. Please scan the QR code and participate with your answers, please. Yeah. So the best way to treat this, as majority of you has answered, synchronized cardioversion. So what we can see here in this step is atrial flutter with the seesaw, with the sawtooth in here in the ECG strip. And why we have this? Because after SVT corrects, it exposes the underlying atrial tachycardia, and that will happen when the adenosine when the adenosine block the AV node conduction. So this look like SVT to begin with, but actually, when you ablate the AV node, it reveals an atrial tachycardia. And this case needs atrial tachycardia to be treated either with a second-line cardioversion, second-line agent, or another therapy like sync cardioversion, because we choose the sync cardioversion as the blood pressure start to drop, and you feel if you feel the baby has poor perfusion, so it's better to start with a sync cardioversion. And another option also, it will be eventually he will need cardioversion or pacing. Second line agents like amiodarone should be discussed with the cardiology, but it's difficult to get the right dose. If amiodarone is giving slowly and low dose, it's often ineffective. And but if it is giving faster and higher dose, can cause hypertension, asystole, and collapse. Another agent will be help with the atrial flutter is sotalol, Cardioverse, and the rate controls. So it's an alternative second-line agent. However, it's also what the main thing is to discuss this with the pediatric cardiology first. So we have here the 5 responses of adenosine. Reversion, and the child will need the cardiac follow-up with the pediatric consultant with cardiology expertise. And non-response, so then we have to think about the 5 Ds and why the adenosine failure happened and how to overcome every step. Reversion, and so reversion, but return again, so recurrent SVT or retriggering SVT, and atrial tachyarrhythmia unmasked like atrial flutter, and this will happen in 10–15% in pediatric population. The fifth response we should speak about is the congestive heart failure unmasked. So if where the child recovers, while the child recovers from the SVT, but the blood pressure starts to drop, and the child get more tachycardic, up to 25% of children with congenital heart disease can present with SVT. But also children who had SVT for more than 48 hours are often in heart failure when they present. So the prolonged tachycardia cause poor myocardial perfusion. And when you return to the normal normal rate, that the baby will have a floppy myocardium that struggles to recover, and the myocardium will be in failure. Myocarditis or myopathy can be unmasked as well. So rarely the SVT can deteriorate to VT or VF, VTAC or VF. So make sure that you be also ready at this. It's very rare complication, but it might happen. This is a new case scenario. We have a 5-year-old presented with shortness of breath and chest pain. The ECG showed the following rhythm. What is your diagnosis here? Please have a look for the 12-lead ECG and then participate with your answer.
Can you show the ECG again, please?
So here the answer, 43% of the participant, they said it's a VT or VTAC, and 43% say that's SVT with aberrancy, and 14% is stating that AV node reentry SVT. So actually, this question, these two answers are slightly actually the same or correct. the SVT with aberrancy and AV node SVT. This strip is not VT. However, it's really confusing, and I can understand that this might with a white complex QRS, and you think it's a VT. However, if you see, if you take a look for the ECG finding, you will find here the ECG. I will show you the AV, the broad complex tachycardia, and easily be mistaken for VT. However, remember that more than 95% of broad complex tachycardia in pediatrics are actually SVT with aberrancy or accessory pathway. Usually a re-entry tachycardia, which make which, if you remember the types, we spoke about it earlier. And that will have antidormic atrioventricular re-entry tachycardia. The finding in the ECG. So you will find here in the ECG the sloping of the QRS and showing the delta wave, and here. And also you will find here the short PR interval. And the SVT with aberrancy mostly due to WPW or Wolff-Parkinsonian syndrome. So it's characterized by the occurrence of SVT plus a specific ECG finding. And that will be a characteristic with pre-excitation, as evidenced by short PR interval, as we said, widen of the QRS due to the antidormant conduction, and slurred upstroke or delta wave, which is dominant here. Sorry. That's what will caused by the ventricular excitation occurring earlier via accessory pathway, and should have occurred via normal AV node alone. And with the onset of SVT, conduction reverse in antidormic way, become to ventricle to atrium in the accessory pathway as a part of the circular rhythm. So I will return back to the first one here. So if you have if there is any accessory pathway, it will return here from ventricle to atrium, and this will give you the antidormic conduction, which will give you the white QRS complex. So, this accessory pathway or aberrant SVT result with anomalous ventricular activation sequence and wide QRS with more than 120 millisecond, followed by retrograde P wave, which may be difficult to differentiate from VT. If you are interested to differentiate the SVT with aberrancy from VT, there is algorithm is called Burgada algorithm. You can follow the question. However, if you have a wide complex QRS tachyarrhythmia, you should first ask the following questions: what is your rhythm? Narrow complex or broad complex, regular or irregular? The second question is how urgent to treat this child, if there is any evidence of shock or congestive heart failure, if the patient is well looking or in distress and having poor perfusion. And then it's worth to follow the APLS guidelines with a wide complex tachycardia. So the WBW, we have here the resting ECG. So this is the resting ECG of the same 5 day. 5-year-old boy shortly after reversion to synaptrism. So here, short also the short PR interval, very short PR interval, then less than 100 millisecond, and the slurred speak is the slurred upstroke of the QRS is more evident here. You can find it here, and which will give you the rise for delta wave. And there is also a Q pseudo infarction or Q wave in AVL. Here, if you can see it well, this is the Q wave in AVL, simply inverted delta wave. And this patient is right axis and having RSR pattern, T wave inversion in V1 in normal for which is normal for age. As I told before, it's worth, if you are confused if this is SVT with aberrancy or it's a VTAC, it's worth to follow the APLS algorithm for the white complex and evaluate the ECG, 12 ECG rhythm, and see if it is white complex or narrow complex, and if the child is stable or not stable to begin with medicine or with sync cardioversion. So in summary, we spoke today about the pediatric paroxysmal SVT, and especially the presentation in infants, as it's very challenging as the child is not verbal and having very subtle symptoms like being not right or poor food or poor feeding, arrhythmia generation and the pathway and the accessory pathway, which will cause SVT with aberrancy, the physiologic interventions like the modified Valsalva and the diving response in children, response to adenosines. So there is 5 responses, is not no response, and you should think about the 5 Ds, how to overcome this. Recurrence or inconsistent or refractory SVT, atrial tachy and mask, deterioration, and the cardiac failure. And these are my references if you want to read more about SVT. And this is the Revert trial with a lot of resources. Thank you. And if you have any questions.
Great, thank you, Marwa. So I was taking some notes of some of the discussion or some of the questions going along, and I think some of these I'm going to answer straight up for you or as part of a discussion, and some of them I'm going to ask for people. I mean, there's 18 people in this group now, so I'm going to ask for some people to give us something back. Okay, so how have you treated various things? Because we want this to be as interactive as possible so that people get what they need from this at whatever level they are at. So first of all, I think going back to the start, when you have a child that we are clearly identifying as an SVT, and you well pointed out that SVT is really an umbrella term for tachycardia as originating above the AV node in the heart. But what we mean by it really, when someone comes into you and says there's a child in SVT, what they mean is a narrow complex tachycardia without the presence of P waves, which actually is really going to be either AVRT or AVNRT, or in someone that's post-cardiac surgery, which is incredibly rare outside the cardiac intensive care unit, JET, junctional ectopic tachycardias. Basically, that's what we are talking about when we talk about SVT. We're talking about paroxysmal SVT. Although I just wanted to, it's like a bugbear of mine. So I feel like I have to do it in every talk. It is really an umbrella term. You could be calling sinus tachycardia SVT by its true definition. So when we start doing things, really what we're assessing is how well is this patient? Do we have time for some vagal maneuvers, and what would they be? So I think we'll start at the start. And someone asked about, has anyone actually dunked a child in a bucket of water? I have. Actually not me, a nurse has. And it was in the neonatal unit, and I've done it a few times. I want to ask the question of people in the audience: how many people have done it, And actually, what was the process? What did people actually do? Because I think it's easy to talk about the diving reflex, but I think in reality, if tomorrow you walk into resus and there's a baby there in SVT, what are you going to do? Where are you getting your stuff? How long are you putting their head in the water? Can anyone talk? Can anyone engage with me? Come on. Anyone, you can type if you want.
Hi, so
Hi.
in our unit, I'm Susanna, I work in Basildon. So in our unit, we had a child, neonate, who had a refractory SVT, was in Evelina at some point and then came back to us. And so he was someone who wouldn't respond to 100, 200, so we'll start from 300. And he was like on propanol, flecainide, everything. But for him, there was a plan from Evelina that don't start medicine until SVT is going on for 10 minutes. And before, in first 10 minutes, we would do this immersion thing. So for him, what we had this sort of fridge. And so where we had a bag of ice, and we used to put that on new baby face initially, and if it worked, and sometime it did work, because he was someone who would have very frequent SVT, so sometime once or twice a week. So yeah, we did try in him and it did work.
How old was this child, Sultana?
So he was a term baby and he was a neonate. So he was and there was so he was initially born in Evelina because this cardiac problem was diagnosed antenatally. And because we were local hospital, so afterwards he came to us. But Evelina thought he would be, ready to go home and he wouldn't have further SVT episode, but he did have as well. So yeah. So he was like, when he came to us, he was, I think, 28 days, something like that.
Okay. I've got someone else typing to me, a bucket full of cold water and ice, 5 seconds twice over. I think formalized, you're meant to count to 10 with the kid's head under the water. And when you look at what people actually do, it is very rarely beyond 3. Because actually, what are we doing? We're trying to drown a child, aren't we? And this is not something that's okay in our minds. People can't do it. And that's where I think that the emphasis, I think actually the buckets of water are happening less often. Please correct me if I'm wrong. But the emphasis is now on what we do in neonatal units, or the ones I've worked in recently, is getting bags where we know where the ice is. You put some water in a bag, a bit like the bag you would get a preemie baby into, although I appreciate you guys are all ED, so maybe you don't deliver babies anymore, but you put a bag that would hold a baby, get a load of ice in it, put some water in it, make it into like a slushy, like you see in the in a swimming pool, but you don't need colors, you just need it to be white. Seal up the bag and put it on the baby's face for 40 seconds. Completely over. I think that takes away from this whole dunking. You feel like they can still breathe because they're not underwater. It will have a similar sort of stimulation, and it'll be more likely to be achievable because you're more likely to put the full ice packet with possibly with a bit of gauze in between so that there's not a burn over the face for 30 or 40 seconds than you would be to actually hold a head under the water for 10 seconds. But that's where we're at. In emergency, I have to say I've never done it in emergency. Because usually no one knows where the ice is. It's usually an adult resus, but the time lag over doing that in an older child isn't there. That's my personal experience. But anyone else want to say what they've done previously in ED to make it more specific?
So yeah, I've done this in ED a few times. And it was in a centre where we had the setup and we knew that this was part of what we would do when children came in. And as you say, so 10 seconds, so swaddle them under 6 months, swaddle them in a towel, so they don't get too cold and so they're not thrashing around too much. And then you really, so it's a bit like the sort of the choking child kind of hold, where you sort of hold them along the length of your forearm and sort of hold their head and then dunk them in and count. And I'm sort of Yeah, and obviously the main thing is really to counsel the parents beforehand, and to have some towels to hand for afterwards as well, so the baby doesn't get too cold. But it is tricky, and it requires some choreography. I was wondering, is the face pack slushy of ice on the face for 40 seconds as effective as a bucket full of ice, or do we have any?
Right, well, indeed, there's not a whole lot of data on that. What the data is on is that the bucket full of ice, people are less likely to hold the child underwater for 10 seconds. So, and then in terms of effectivity, you're really comparing a maneuver you're likely to do properly with a maneuver you're likely to underdo. And I accept that when you're talking somewhere like this, you're like, no, I will do it, I will. But actually, when you're holding a child's head underwater for 10 seconds, it's quite a long time. So unless the parents have been through it before and they know what to expect, which sometimes occurs on the neonatal unit when children are having this over and over again. So I do personally think it's quite a hard thing to do properly, merely because of how it feels. Which will bring us on to actually the diving reflex versus other vagal maneuvers. Now, the diving reflex really is a vagal maneuver of a type. It's encouraging you to take a deep breath. And when you talk, actually, when you're talking about the way that you hold the child, actually, if you hold them on their back with your hand on their front and then dunk them like that, you also get the going from supine over, which also increases the breath holding. So it probably is more effective the way you're doing it there. But then other vagal maneuvers, as the children get older, they can start to do more themselves. And I wonder what other vagal maneuvers have people, I mean, I see these children in my clinic, so I counsel them about vagal maneuvers. So I can tell you all what I counsel them, but what other vagal maneuvers have people tried in a cardiovascularly stable child in the emergency room with a heart rate of 300? What will you ask them to do?
So if they are older children, so just
older, so maybe 7 or up, something like that.
Yeah, so maybe just as I mentioned, to blow up in the syringe, just try to move the plunge.
Yeah, perfect. Blowing a syringe, blowing up a balloon, squatting and blowing up a balloon kind of doubles up the effect. And there's been a really, I thought, quite a funny actually study on headstands recently, handstands in children. And there was a group, I can't remember exactly where they were from, but they got about 20 children to do handstands, and they found that actually reverted them in the majority of cases. I am now just waiting for the next SVT that can do a handstand to come into resus, because that's what I want to do. That would make my week. I think that the study is too small really to show significance, but there's now a case report came out in the BMJ a few years ago about a child that had refractory SVT, and that's what she was doing at home. So there's actually sort of case-based evidence that going upside down quickly, probably because you are also increasing your intrathoracic pressure and closing your epiglottis in the moment of doing that. So kick handstands. I don't think it works if you help them get up. I think they've got to kind of get up themselves, or at least be quickly put upside down. And then if you imagine when you're upside down, it's a very long time since I did a handstand, but when you're upside down, you have this kind of breath hold. You've got to sort of focus on breathing, and you've got this breath. I think it's just an expanded vagal maneuver. So there is some emerging case-based evidence that doing a headstand or a handstand might be helpful. I've never personally used it in resus, and I've yet to counsel any patients in clinic that would be a good idea. But if I had an athlete or someone that did a lot of acrobatics, I might. What my typical clinic counseling would be, depending on the age of the child, would be giving them some syringes to blow into and showing them how to do it, or asking them to blow up balloons. Some people, like certainly children I've heard of that have have come to me in clinic. Actually, part of the way I ended up diagnosing their SVT was because they said what they had to do after they felt really odd, got this kind of head spin, maybe some palpitations. Children are very poor at describing palpitations under the age of about 7, from my experience, at describing them in a way that we understand. I mean, they describe something, but it's not necessarily what you would understand to be palpitations. What this child was doing was they were suddenly stopping, not losing consciousness, squatting and asking for a drink of cold water. And actually that led me to the diagnosis. So of course there were still a lot of tests to do to capture that rhythm, but it became more clear that that was them actually creating their own vagal maneuver. So squatting, I tell them, cold drinks, I mean, in theory, it helps, it makes them feel better. I don't actually think that there's the amount of cold you need if we're talking about 10 seconds underwater in a drink to make it help. But I would go with balloons, syringes. The next time I meet an acrobat, a handstand, and they are the ones I typically counsel in clinic. I'm very aware of time. You probably don't want to hear me talk too much, and you're going to have to hear me talk for the next half an hour. But one thing I wanted to make the point of, and we can, if we've got some more time, I'll run through all these other questions I've got written down, was around, what was it around? Two more actually. Refractory versus recurrent. Up to what age would you dunk in a bucket? Probably about 1 is the answer. And the squat is for as long as it takes for them to feel better. The refractory versus recurrent SVT. So refractory SVT really truly means something that is not responding to your maneuvers. And I think we've got the other possible options here. Is it something that's just not responding? Is it that we're not getting the drugs in quick enough? Is it that it's something different? Okay. And that was all gone through on Marwa's slides. Recurrent SVT is slightly different, although can have similar reasons than refractory SVT, is when you see that the rhythm stops, and then you immediately go back into the rhythm. So you've given whatever it is, 100 mics per kilo. If that has absolutely no response, you would go up. If you end up on 300 mics per kilo, what you see is you see the sinus pause, then you see it going back into something that looks like a normal sinus rhythm, and then suddenly you're back in SVT again. Going up and up and up and up and up on your adenosine is very unlikely to work in that scenario, because what you are, and adenosine is not an antiarrhythmic, okay? Let's be clear about this. Adenosine blocks your AV node. It allows your heart to do its own thing and get back into a normal sinus rhythm, but it does not have any long-term antiarrhythmic properties whatsoever. It is pretty safe because it's got such a short half-life that almost by the time you've given it, but certainly 10 seconds later, the stuff is being processed and it'll be weed out with your next urine, right? So it's pretty safe, but it's not going to give you any long-term gain on there. So if you're seeing someone that is going back into sinus rhythm and then going back into what it appears to be SVT, you need to think about how you are going to keep them out of SVT. So is this because they are triggering, or so you need to treat their fever, their electrolytes, their pain, something that's making their heart drive faster, or is it because we have got not enough control of their autonomicity? So you need a beta blocker or something like that. And that usually is with discussion with cardiology. That is a long-term antiarrhythmic. So sometimes you do need to use them together. But these children are generally pretty well and pretty stable. And the last point I was going to make was around the last question, which was a tricky one actually, because there were a load of right answers, to be honest, is the child that we showed you with, who's 5, who has a broad complex tachyarrhythmia. Honestly, in emergency, let's be clear here. It is very difficult to know whether that is SVT with aberrancy or VT until they've actually cardioverted, or if you know what their baseline ECG looks like. On the balance of probability, it will be SVT with aberrancy in every single child that you see with a broad complex tachycardia, but that's not the safest decision to make. So in children that are cardiovascularly compromised, you absolutely, as Marwa said, follow the APLS algorithm and treat it as if it's ventricular tachycardia. That is the answer. If you know, for example, the child has got a big substrate for arrhythmias, so they've had cardiac surgery around their atria that's interrupted their bundle, that they've got a baseline, these would be known to cardiology, right? So they've got a baseline ECG, which has got a right bundle branch block, and then they go into a very stable tachyarrhythmia, and you know that they have been in SVT before, it is a safer decision to make. Or if you know that they have got a delta wave on their ECG, then, and they're stable, again, giving a trial of adenosine would be reasonable, but I think these are in quite small, very specific personalized cases rather than just your kid off the street that's got a broad complex tachyarrhythmia. So that was it. There were a few other questions, but I think that we could probably have talked for 2 hours about SVT because there's lots of little interesting little pieces and everyone's had a case of SVT. But if we are okay, and if anyone wants to put more questions in the chat, please do. I'll try and answer them all. But if we're okay, I'm going to move on to talking about syncope. Is that all right, actually?
Yeah, that's
Okay,
absolutely
let me
fine.
try.
And I
and
know
share
that
screen.
you're clinical as well, but you're welcome to stretch the session to 1:15 if that's convenient for you.
Sure. Okay, I have not been called yet, so we'll see how we go. All right, can everyone see my slides? Can we see them? Yeah,
Yes,
cool.
we can
All right.
see. Yeah.
Amazing. Okay, so what I can't see is you while I'm looking at my slides, which is really irritating. I should probably get a double screen, but work haven't yet got the funds. So what I wanted to go through is far less adrenaline provoking, to be honest, but far more common. And actually, I get asked questions about this every single day. And I think every single day, probably even on my off days. And I also get a huge number of direct referrals into my clinic for syncope, which I am not saying is wrong. Refer me anything. I accept basically everything. But I think actually with good ground knowledge, ground floor knowledge, we can actually appropriately reassure the majority of people and also reassure ourselves, because I think some of the issue around this is that we're worried we're getting it wrong. Not that actually when you really, if it was just a case in a textbook, you would, or an exam question, you'd be like, tick, 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 this is all okay. When it's a real person, I think we have a greater level of anxiety, and we have to acknowledge that, and therefore fall back on good information, good evidence, and good guidelines to make sure that we're making the right decisions, even when we have this little inkling of worry, because everyone's worried about cardiology, everyone's worried about the heart. Okay, so the way I intend to do this is like Confucius. If I just talk to you, you are going to forget. If I show you some ECGs, you might remember them. If I ask you to give me some answers about the ECGs, I really hope that you're going to understand what I'm trying to get at, and therefore be able to apply it in the future. So the basic outline of this talk is here. What are we really trying to achieve in emergency? Is it a minute diagnosis of something random that the cardiologists will love you for? You know, short ventricular tachycardia, long QT or short QT or something really odd, long QT type 3. No, right? The cardiologists don't want us to do that. What we need to know, the cardiologists don't want us to do that because then they can't, but also what we need to know is which children really are at risk here. Where are the high risk children? Which ones are borderline? Which ones need more investigation? And which ones do we counsel not to exercise? That's important, versus which ones can we really clearly reassure and safety net. And I think that that's more about recognition of who's high risk and who's low risk, over and above diagnosing and knowing everything about some of the inherited cardiomyopathies or inherited heart diseases that cause arrhythmia. That is my feeling. And I think that that works on a shop floor level. Don't get me wrong. I still love the thrill of a diagnosis. So please don't misunderstand me here. But I think what we've got to do for the majority is know what it's not. So we're going to go through some normal adolescent ECG patterns, because the majority of children that are syncopal are usually around 12 and above. And what worrying ECG features would worry me, and then a bit of a chat about syncope. And the thread going through this is going to be recognition of patterns that represent inherited heart disease, arrhythmogenic inherited heart disease rather than structural inherited heart disease on an ECG. So let's start with the definition. I think probably all know what syncope is, but just to make sure that we're all starting from the same starting point, it is an abrupt and transient, complete loss of consciousness with an inability to maintain postural tone. You can't save yourself. Okay, once you are going, unless you have got a tiny bit of warning and you already get yourself to the floor, you can't save yourself from doing this. So if you're somewhere where you can't sit down and you don't want to lie down, you're going down and you're going to hit your head on the way. There is then a rapid and complete recovery, and the presumed mechanism is always cerebral hyperperfusion, but because it's so transient, it's very difficult to prove that this is what's happening. Below this, I've got there's loads of subtypes of syncope, and if you're truly interested in syncope, there's about 100. I overstate, but there's also a guideline on syncope, and you can look up all of the different subtypes and what their criteria are. But I'm going to focus on two. That number one being cardiac, not number one because it's the most common, number one because it's what we're looking for. And that is syncope that's caused by, and proven to be caused by, either a change in your heart rate or your blood pressure, or due to a low cardiac index. So your left ventricle cannot pump enough blood to maintain your cerebral perfusion under certain environmental circumstances. So either because it's not pumping enough or it's obstructed, so the outflow tract's obstructed. So effectively summarized, that is a rhythm change that stops your cerebral hyperperfusion, a blood pressure change, a left ventricular mass issue, so something that means it's not pumping as strongly, or when it does pump, the blood flow is obstructed. Now, all of these things don't have to happen consistently, okay? They can be caused by changes in the environment. So when you're under exercise, can the obstruction be more? Yes, of course it can. So some of these things will only occur in certain circumstances. So that's the least common, incidentally, cause of syncope, but the most important. The other is vasovagal syncope, mediated by the vasovagal reflex, and typically it's postural. You get a few seconds of a sort of characteristic feeling, like a hood coming across you, like sort of dark shadow coming across your eyes, sometimes some speckled vision, feeling like you're a bit dizzy, not being able to get some words out, sometimes some hearing change. Then what you can prove in people is inappropriate bradycardia, a fall, and often these children or adults, adolescents, young people are quite tired for some amount of time afterwards, but they are not confused. So they don't remember the event, but they're not confused. I think that's quite important, because what I don't go into a lot here, but what is a problem on the shop floor is this a seizure, okay? And so actually lots of these things have overlaps, which is difficult to weave into one single half-an-hour presentation. But I think the seizures, we often can look very similar in those few moments. What you have that is different is sometimes the way in which the aura presents is different, and then their recovery is often very different. So the actual moments that people that fall because of a vasovagal problem can shake, they can have eye rolling, lots of things that you do see in seizures. So it's important to know that the fatigue is normal, but confusion and drowsiness is not. So these two, because they're the two that are related to what I'm going to say. So let's start at the start. This is a 12-year-old boy who's had a syncopal event during a school sports day. What I want you to do is, I'm assuming a basic knowledge of reading ECGs here. And if you ever want me to talk about ECGs inside out, how to read them, etc., I'm more than happy to do that. But this, I'm assuming a basic knowledge of ECGs. So have a scan of this ECG. Imagine this was thrown in front of you. Can you have a quick look at this ECG? The kid's fainted in a sports day. Is it fine? Can you just go from triage? And maybe that's not the question, but you know what I mean. Do people scanning the ECG think it looks normal? Just put by Y or N in the comments. Yeah. So norm, or yeah, Y for yes, it's normal, N for no, it's not. And I'll have a quick look. Okay. All right. Not normal. Okay. Does someone want to just quickly extrapolate, anyone, on what's normal? So somebody's saying it is normal. I was a bit confusing. Maybe N is like normal. Prolonged QT. Okay, someone thinks it might be a prolonged QT. Okay, so let's look at this in a bit more detail then. I'm going to zoom in. I appreciate I've not given you the leads here, but I'm going to zoom in on this 12-year-old boy's ECG. What we are seeing here is, if you trust me that there's a normal axis, that was normal. In the previous ECG, the rate is pretty slow actually. Pretty bradycardic. You would do 300 divided by the number of big squares between two RR intervals, which here is 1, 2, 3, 4, 5, 6. He's going about 50 beats a minute. He's pretty slow, isn't he? So he's got sinus bradycardia because we can see normal P waves. He probably doesn't have a delta wave. And I've zoomed in on it for you so that you can see that here the PR interval is normal. I hope you can see my marker. The PR interval here is within normal limits, just over 3 small squares. There's a reasonable angle here. There's not a sloping up here, so there's no delta wave. You then have a pretty normal looking QRS, which is within 3 boxes, which again is normal for this age group. All these tables are online. A flat horizontal ST segment going into a T wave, okay? And then I appreciate the comments about long QT syndrome. If you calculate this QTC, it is normal. And also the way of scanning an ECG like that would be to say, as a scan, I would always advocate calculating it properly. But if you look at where this T wave peaks, if it is less than halfway between these two RRs, it is likely that QTC will be normal. Okay, that's as a scan. Okay, so my feeling on scanning the ECG when I scanned it was that it was pretty normal. Okay, so but like I said, if you're saying no, the question you've got to ask yourself is why, and if there is a why, then you look into that. So that's absolutely appropriate. So what we're going to do, we are coming back to that, boy, don't worry. We're going to talk about pediatric ECGs and why people hate them, right? People really hate them or find them annoying or whatever. I really love them because they make sense, right? If you understand them, they make sense. But I'm going to talk to you about the reasons I think that people hate them. And this is based on a bit of experience, a bit of teaching, and a little cohort study I did on some of my unsuspecting colleagues. Suspecting as in they gave consent, but I did a little study on what they were getting right and wrong about ECGs a few years ago. So first of all, axis. People don't like axis. I think because it varies across the age spectrum. People are not quite sure when the axis should be rightward and shouldn't, and it can vary quite radically during your adolescent period. And in fact, in trained, healthy adolescents between the age of 12 and 16, it can even go a bit negative, a bit leftward. So that's a massive variation across your age spectrum. Early repolarizations, big problem in pediatric ECGs. This is where your ventricle starts to repolarize. So after it has depolarized, which is the QRS complex, it starts to repolarize before your T wave, which is the true repolarization of your ventricle. So something starts happening with ion movements across your myocytes before that true T wave starts. And that creates something that looks either like ST elevation or like a little notch there. And so that is pretty common in pediatric ECGs. Around 1 in 20 ECGs will show you that. But actually it's for some people hard to delineate from other things. And it largely is improved by the time you're an adult. So if you're used to looking at adult ECGs, then ST becomes really important and we don't talk so much about early repolarization. Hypertrophy, and I'm talking about left and right ventricular hypertrophy. There is a shift in ventricular dominance from when you're in utero to when you are born to when you're an adolescent. And that gradually goes from right ventricular dominance, which is only really seen in utero or in premature babies, but then they're very equally dominant during your very early days and weeks of life, and gradually that shifts towards being left ventricular dominant, which is your main, in a normal heart anyway, which is your main pumping chamber for the body. And that shifts over the course of your life. And what it can create, and in different physiques of children, it can create this appearance that you have got huge complexes in your left ventricle. And people worry about left ventricular hypertrophy and therefore by extrapolation, hypertrophic cardiomyopathy in these ECGs. And not without reason. You know, some of these complexes look big, but that appears and it can be normal. And that's another thing that is different about pediatric ECGs. The other thing is T waves. They change over the course of your life. They have an inversion pattern that all the T waves up to lead V3 and sometimes even V4, depending on how you place your markers, will invert by the end of the first week of your life. And then they slowly resolve over the course of your childhood. So if they are downgoing in 1, 2, 3 by the end of the first week, over the course of your childhood, V3 will reinvert, followed by V2, followed by V1. However, in some adolescents and even in some adults, you have continuous inversion of lead V1 for the rest of your life, which is normal. So knowing what is right and wrong for different age groups in every part of your ECG, I've just gone from start to finish, is difficult. And I think that creates a bit of uncertainty around what you're reading. And ventricular ectopy, love it. It's in everyone, basically. When I tape my adolescents, most of them have some ventricular ectopy, but how much of that is normal? And at what age group should we be expecting a higher or lower ventricular ectopic burden? Tricky, okay? So I think these are all the reasons why people find pediatric ECGs difficult, but I still think they make sense. They're a nice puzzle to work out if you like puzzles. So helpful history. We're going back to our 12-year-old. Remember his ECG, we scanned it. Some people thought it didn't quite look normal, and we're just processing why. Some people thought it probably did look normal, but we scanned it and it doesn't look radically abnormal. I think we can probably agree on that. So what's going to be helpful about his history? Because we want to know, is this a cardiac problem or is it not? And in on balance of probability, he's not going to have a cardiac problem, is he? Because it's less common. I've already told you that. But actually, we want to find the one, right? And he could be the one. So if the history here is going to be super helpful because his ECG is not going to be that helpful. If he has got a cardiac problem, the likelihood is either he's got a known previous cardiac history. So he has had congenital heart disease surgery or has had unoperated congenital heart disease, remains having an AVSD, which is unoperated, something like that. The prodrome is brief, if at all. So something has happened very, very fast and he had no idea it was coming. So you don't get visual changes and you don't get some hearing loss and you don't feel a bit sick and your friends don't catch you because you've not said, something's wrong. Your friends aren't catching you from a cardiac collapse usually. Exertional. This is helpful actually. When you have syncopal episodes, clearly loss of consciousness with no warning at peak exercise. So you are sprinting to the line, or you are going for a ball in football, or as the goalie, you have jumped to save the ball and you lose consciousness in that moment. That is a problem. That is much more likely to be what we call exertional syncope, which is much more likely to do with the strain your heart is under at that moment, and therefore cardiac. So then it matters, right? That all we've been told is he's at a sports day, right? What if he was sitting watching the sports day in the sun, not drinking anything, stood up, got some visual change, fell over? Less concerning, right? But no, he was in the sports day, sprinting for the line in a 400-meter race, wanted to beat his best mate, and fell over the line, winning the race, importantly, but fell over the line, lost consciousness, eyes rolled backwards, turned over, woke up, didn't know what happened. That's more of a problem. Okay, so the history is going to be super helpful to you. If his cardiac examination was abnormal, these are not all pointing to the same things, you understand. These are pointing to risk factors which raise the risk of it being cardiac. And if we know his family have got an inheritable condition, he should already be in follow-up. So, and the non-cardiac stuff is basically the inverse of all of that. But if you've got a really clearly identifiable prodrome, children that faint every time they see blood, I don't get too concerned about. Their examination is normal. And the more frequently occurs with similar characteristics without any proof, almost the more reassured I feel. And also the more likely I am to capture it on some sort of monitoring like a tape. Okay, that's not emergency, but that is the sort of forward movement of these children. So this boy actually has CPVT and is in my clinic. I'm not going to click on this YouTube link, I don't have time, but it is interesting. Christian Eriksen, if you don't know him, is a Danish footballer. Danish, is he? Somebody can tell me I'm wrong. I'm sure it was Danish. Could be from the Netherlands, one of those two countries. But he's a footballer, and in last year's World Cup that was delayed, he sprinted for a ball, and you can watch this video on YouTube. It's not voyeuristic, don't worry. You don't get to see his resuscitation, but you can see how quick. He didn't know. He clearly had no idea. He is sprinting for the ball. He does not trip. Very important that he had a good stride, and then he is down on the ground and he's rolled over by his colleague. No warning, no idea, very fast. And so I don't know if he's got CPVT or not, but he certainly has a cardiac reason for his arrest. And I put that up there because it's an interesting video to watch to give you an idea of what sort of history people would be describing. So the boy that I'm describing does have CPVT. And what is that, right? Catecholaminergic polymorphic ventricular tachycardia, not as uncommon as you might think, although it's not particularly common. Around a 1 in 7,500 to 1 in 10,000 diagnosis. Not many, but if you're going to see a child that's syncopal every single day of your career, over the course of your career, you might come across one of these, okay? The important thing about this one is it really does all pivot around the history, because the ECG at rest can be completely normal. You might at best see some ventricular ectopy, but you see that in a lot of children. The changes are only really induced under the strain of catecholamines. So usually exercise or something that massively raises your heart rate, so a shock. It causes ventricular ectopy. It's polymorphic in nature, so they look of all different types, and that might help you on an ECG if it's not normal. If you see lots of different ventricular ectopics of different types, so they look all different, rather than just one morphology of ventricular ectopy, which is more normal, then they are at risk. And really the history, like I said, is your friend here. An unprovoked collapse with syncope definitely needs investigating, and that needs to go to cardiologists. What these children need is a tape, but they also need to be advised not to exercise until they've had an exercise test, because we can put them on the treadmill and we can make some exercise and we can watch for these ventricular ectopics coming out. It's not a difficult diagnosis to make if you've got the right test, and if you have access to the right test. So that puts that boy to the side. Whistle stop tour, by the way, I forgot to mention that, around things I see in emergency. The next one is a 14-year-old boy who has chest pain during football. Now, I say chest pain, this is not really syncope, is it? So it lies in the face of the title of my talk. But actually, lots of these symptoms will come before or after feeling dizzy, and chest pain and palpitation is very common to hear. So at a scan of the ECG, can I ask people again, I feel like yes and no is not a good, so can you just write the word normal if you think it's normal? And if you don't think on your scan that it's normal, what's the problem here? So just, you know, whether it's P wave, QRS, delta wave, T wave, I don't mind what you put, but just so that I've got an idea of what people are scanning and what they think is abnormal. Okay, so we've got some not normals here. He was Danish. Okay, good. The T wave. Yep, someone thinks the T wave's not normal. Okay, R waves. Right. Okay. Okay, so people are focusing on the right thing here. Okay, so the R waves are pretty big, and there's T waves that are abnormal. Okay, so I think on your scan, bear in mind that we've not gone through the whole how to systematically read an ECG, which I would be more than happy to do. But on your scan, you're thinking, look, stuff across here doesn't look normal, right? And that's where you then focus. So of course you read the whole ECG. You're going to check, is he in sinus rhythm? Yes. Does he have P waves? Yes. Does he have a delta wave? Probably not, although this is a bit upsloping, so you'd have to check how long his PR interval is. You do all of that, and then you're saying, actually, I'm really focused on here. And what does that mean, right? So this stuff, these V4, V5, and V6, though, think about where those markers are being placed. They are being placed around the side of the left ventricle. So something is making this left ventricle shoot out a lot more electricity in terms of number of volts, because up and down on your ECG is a voltage criteria, right? So it's shooting out a lot more volts in this around this side than it is on the other side. So this is your left ventricle shooting out more electricity. The other thing that's happening, and people have correctly identified, is there's something going on with these ST segments, and there's something going on with these T waves, right? They should never really be, across your whole childhood, be inverted in V4, V5, and V6. This 14-year-old boy is old enough now to have re-inverted his T waves in V3, followed by V2, followed by V1, which he has done. But he's got T wave inversion here. When did that happen? We probably won't know. We probably will never find out. Has he had it since birth? We don't know. But this is not normal, okay? So we are now focused on these things, and these are electrodes that are placed around the left ventricle. Really important, okay? So again, I'm coming back to him, but I want to weave into this. What are we really looking for in syncopal adolescents, or anything, actually, chest pain? We're looking for a substrate as to why they've had a syncope, okay? So we're not looking for the diagnosis. What are the substrates for an arrhythmia or syncopal arrhythmia in emergency? Do they have a delta wave? Do they have Wolff-Parkinson-White? Now, actually, although a substrate for an arrhythmia, Wolff-Parkinson-White very rarely causes actual syncope in children. They get a lot of symptoms, but they don't usually fall over. So I would definitely look for it. But I think that in terms of children that are actually having fainting episodes, that is less likely to be your answer. The other substrate for arrhythmia would be problems in the left ventricle. So cardiomyopathies. Hypertrophic cardiomyopathy is the most common in childhood. It's around 1 in 500, unless you've got other features of dilated cardiomyopathy. Those two sort of sit hand in hand. They have got slightly different substrates. But in terms of arrhythmogenic potential, hypertrophic cardiomyopathy has a higher arrhythmogenic potential than dilated cardiomyopathy. So you're looking for features of hypertrophic cardiomyopathy. Long QT syndrome is another one. We all calculate the QTC. Do we all calculate it? Do we read the little box at the top? I don't know, but probably we should be calculating it. But actually, long QT is the substrate for arrhythmia. Okay, day to day, most of these children don't know, but actually that's a substrate for them having an arrhythmia, which would be a ventricular arrhythmia, and then more likely to make you faint and be syncopal. Okay, so these ones after Wolff-Parkinson-White, these are all substrates for ventricular arrhythmias, and that is more likely to make you, from a cardiovascular perspective, collapse. ARVC is arrhythmogenic right ventricular cardiomyopathy, which actually can be biventricular, similar sort of chaotic ventricular activity to hypertrophic cardiomyopathy in terms of electrical activity, much rarer diagnosis and much more likely to be in your later teenage years or in fact into your adulthood. So we don't see a huge amount of this in children. And Burgada is another one. Burgada, named by the Burgada brothers, who are shockingly, actually, I felt, still alive. I feel like everything that's got a name named after you should be dead. Is that bad? But they are, in fact, still writing papers. And they found in adults that if you have a broadened QRS complex with some right bundle branch block pattern and some changes in the right side of your heart, so leads V1, V2, and AVR, that show you cove-shaped ST segments, that your risk of arrhythmia was higher in adults. And this has subsequently become known as Burgada syndrome and has a sodium channel mutation associated with it. This is what we are looking for, right? This is what we are trying to find. And actually, when you look at an ECG and it's normal, know it's normal, but also know you've excluded the obvious signs of these things that I've just been through, okay? So come back to our 14-year-old boy. We've all identified these things, and we're all now saying, this side is across the left ventricle. He's got some T-wave inversion. That means his ventricle's not repolarizing properly. Something is changing about the way it's repolarizing. So what does he have? He's got voltage criteria for left ventricular hypertrophy. right? Which this is important because that could mean he's got hypertrophic cardiomyopathy, okay? And in this talk, in the context of this talk, you'll probably already know that he does. But it is also important because you will see this on a lot of children. And this is the Sokolov-Lyon criteria. I do not expect you to remember their names. They are very Googleable. But these criteria are for looking at voltages on an ECG in pediatrics, although they were first calibrated in adults, and it's how you calculate it, okay? And what they want you to do is look at the S wave, so the downward deflection in V1, and add it to the R wave in V5 or V6. And if that is over 35 millimeters, which is across here, so here, that is now making criteria. What you can see in work, this work was done in the Netherlands, which is why I had my little moment of madness about the Netherlands and this definitely, and Denmark. This is definitely from the Netherlands, where they looked at lots and lots and lots of pediatric ECGs, and they calibrated them with the left ventricular mass on echo, and they looked at children where they're here, right? So they're pretty borderline for having left ventricular hypertrophy. However, all these echoes were normal. So what I'm saying is, in isolation, left ventricular hypertrophy, probably realistically under about 40 millimeters on a pediatric ECG without any other criteria, is pretty normal, okay? Again, what we do have on his ECG is we have something else too, right? We have some changes in his T wave. Importantly about a left ventricular hypertrophy, if you look at the sensitivity and specificity of that on pediatric ECGs, if you look at only voltage criteria for LVH, so that's you meet voltage criteria, but that is all you meet, the sensitivity of that is only around 25%, meaning, and I only say this, I'm sure you guys all know it, but I have to look it up every time. The proportion of children with left ventricular that meet the criteria for left ventricular hypertrophy who are also positive for a disease, so how come, it's not high. The specificity is, okay? So if you don't have, inverse of that. That's why I always have to look it up. If you have hypertrophic cardiomyopathy, you're very likely to have left ventricular hypertrophy. If you have left ventricular hypertrophy, but only voltage criteria on your ECG, that does not equal the same thing. So lots and lots of children have it without having the disease, but most children who actually have HOCM have the disease. Does that make sense? If it's not, put something in the chat and I'll try and re-explain it. So what we are looking at then is we found the left ventricular hypertrophy. It is actually pretty big. We're well over the 35 millimeters here, aren't we? We're probably up about 50 or 60. But what else do we want? Okay, we want something else too, because the sensitivity of this is not high unless you get something else, okay? So we found it already. You already put it in the chat. We've got T-wave inversion here, which shouldn't be there. So we've got repolarization abnormalities. We've probably also got some early repolarization changes, which in isolation means probably nothing, but now we're putting them in with other things, is a change in this child's ECG. So what we have got now is a child with an ECG that shows both voltage and additional non-voltage criteria for left ventricular hypertrophy. Additionally, he's got a normal axis, but other children might have more of a left axis deviation or the feeling of left atrial enlargement, so a longer period of a P wave, so a P wave that's going over a longer time, so broad base to the P wave, possibly with a notch in the top. He does not have these, but these are additional possible non-voltage criteria. So if you can have voltage criteria plus one or more of these, the red one being what he has, then your risk threshold for him having something cardiac going wrong with his left ventricle, most likely hypertrophic cardiomyopathy, but other things too, shoots up, okay? So he does have hypertrophic cardiomyopathy. And the important thing is that an ECG does have diagnostic features in children that we know to have hypertrophic cardiomyopathy in around 90 to 95%. However, the problem is these are not all one diagnostic feature. Otherwise, I would just tell you what that was. The changes, what change you have on your ECG doesn't really correspond to your arrhythmia risk. That's more to do with what mutation you have. And not everyone with HOCM has a definite genetic mutation. So actually, knowing what changes you have on your ECG will help you make the diagnosis. It won't help you know how to risk stratify their chance of arrhythmia going forward, but that's definitely more in the domain of the cardiologist. And the most common changes are repolarization abnormalities and pathological Q waves. So Q waves that are greater than 3 to 5 millimeters going downwards before your QRS complex. Small Q waves are normal on pediatric ECGs. When they get too big, that would be pathological. So these are the most common changes. quite recent studies come out of Great Ormond Street looking at ECGs in children with hypertrophic cardiomyopathy. So they've got a big cohort there. That's where lots of children go. There's a big cohort also at the Brompton, which is where we refer ours to. But they all get looked after centrally, and they keep quite control of these children that already have left ventricular mass changes. And if you look here, what they've seen is across the different things that could be on your ECG, here's the occurrence in children that definitely have hypertrophic cardiomyopathy. It's not really one. There's not really one thing that comes out over and above the rest. Left ventricular hypertrophy is the most, but it's still only 2/3. Okay, so you're looking at 1/3 of children with HOCM who are likely to have an ECG change, because we know 95% of them do, but it ain't that. Okay, and an ECG risk score greater than 5 means you rack up 5 different things. Okay, so really, if you look at these two things, this is what you're looking for together, and that from a ground level will really increase your chance of picking something up. All right, last one. I'm getting there, actually. I think I've caught us up. This is a 15-year-old girl, so a slightly older adolescent, does a lot of dancing, and she has her first ever syncopal episode when she's drinking water after a dance class. Can we do the same thing? And if everyone just scans along this ECG and says whether it looks normal or not, and if not, you can put normal, or if you put not normal, what it is you're focusing on. Okay, thanks for answering first, Rajan. Abnormal, widespread T-wave inversion, and possibly a prolonged PR interval. Okay, yeah, I can see where you're at there. Prolonged, maybe borderline, but I see where you're there. If everyone's got my pointer, we're looking at from the start of the P wave to the first downward deflection here, and that is 5 boxes, which makes the PR on a standardly calibrated ECG, which this is. I just had to cut it off for the patient details to get the patient details off the slide. But in standard calibration, each small box is 0.04 milliseconds, 0.04 seconds, and that makes this 0.2 seconds, which is just on the cusp of being normal. On the cusp, though, I agree, it's borderline. Anyone else want to respond? Okay, so we're going to move on, mostly in the interest of time, but I think we're getting the feel that people don't think this is normal. And I hear where you're at with this P wave and widespread T wave inversion. Okay, so really important. I think what I'd also bring to your attention, here's the T wave inversion we're talking about. I'd say PR, I agree with you, and I think it's a good spot actually, but probably will, for her age and for her resting heart rate, fall within the normal range just, but I agree that that's borderline and would be worth looking up. The other thing I'd encourage you to look at is the axis here, okay? So we look at axis in lead 1 and lead AVF. And so what we are looking for in a normal pediatric ECG, the majority, not at the extremes of age, will fall within 0 and 90 degrees. And that would require an overall upward deflection in lead V1 here, which we don't have actually, and an overall upward deflection in AVF, which is plotted downwards on that little chart with the man standing like he's Leonardo da Vinci. So we do have that, okay? So we are now going to be saying that that's actually more downward than it is upward, okay? So if we are saying that this is 2 or 3 boxes downward, we are going to have to plot this vector. So it's an electricity vector, it's a current. We're going to have to plot it backwards along the lead 1 line, which means we are going to go into the slight right ventricular, slight right axis quadrant, which might be normal in a neonate. But in a 15-year-old girl, we'd be expecting really to have her into left at the left axis by now. We would probably expect it to be also, if she's depending on how much dancing she does, for her to be quite physically fit. And in fact, by 15, if she's gone through puberty, if she's also been athletically trained for a long time, she may well actually have borderline left axis deviation. So that makes almost this even more abnormal in her. So that's another thing on the ECG. The other thing we see, and this is where this whole early repolarization thing gets muddled up a little bit, is you see these little, this is what this arrow is pointing towards, this little sort of knobble, is the best way I have of describing it, I'm afraid, after the QRS complex. And that is called, and again, this is in context, right? So we have now got T-wave inversion, we've got an abnormal axis, and now we've got a knobble. I think we're now putting things together. So we are magnifying her risk by lots of different things that she has. So the more things you end up with, the more likely that is to contribute to what I would call a higher risk patient for having a cardiac diagnosis. That is called an epsilon wave. Okay, and an epsilon wave is an abnormal deflection in the first 40 milliseconds after the QRS complex, and it's usually seen in the right-sided lead. So in V1 and V2, and you can see it in both of those leads on her here and here, and sometimes in AVR, and you probably can just about see it there, although her T wave is very flat in AVR, so it's difficult to know exactly where that is, but I think that's the knobble there, and that is called an epsilon wave. We're coming back to her again, don't worry. So let me summarize a little bit about syncope and adolescence. I think we see it every day. It's a transient loss of consciousness, cerebral hyperperfusion. It should be rapid onset, short duration, and there should be a spontaneous recovery. And the final common pathway here is reduced perfusion. The frequency is high. The frequency of it being a vagal, a non-cardiac cause is incredibly high and will be the majority of people that you see. However, we really want to be alert to the possibility that this could be a first presentation, especially in adolescence and especially around puberty, of inherited heart disease that has an arrhythmogenic potential. And therefore, I'm asking you to start looking for signs of WPW. So look for your delta wave, although syncope less common. Symptomatic patients are not. They are symptomatic if they're going in and out of SVT. Look for signs of long QT. Look for CPVT in the history, actually, but also the small things that you might find on the ECG. Look for signs that there's something wrong with the way that these ventricles are balancing up. I don't need you to make the diagnosis of ARVC or of HOCM or of dilated cardiomyopathy for that matter. None of these are actually made on an ECG, really. What I need you to know is how, when the ECG criteria start racking up, what they are, how they contribute to risk, and then how to refer that to cardiologists, because I'd argue this girl needs a relatively urgent referral. So what are we going to do? We're going to do really good history. I really like 3 generations of a family history, and I know it's really annoying, but cousins, aunties, uncles, they fall within 3 generations, I'm afraid. And I do live by my words. I do 3 generations in clinic, and that is because sometimes you'll find something you're not expecting. A drowning without any cause, without anyone really knowing why, and a really good swimmer, a car accident, something that's not been investigated, or more than one person with odd histories, a car accident, a drowning, a this, a that, the other. Actually, are these all relatives within 3 generations that have actually had cardiac syncope, but then have had it in a situation which means their cause of death hasn't been easy to identify? That's possible, okay? And you do occasionally find it. So 3-generational family tree, looking for signs of someone that's had a syncope or collapse that's been undiagnosed, and especially sudden adult deaths in young people under 35. Clear triggers, and that would be out with the standard risk for vasovagal. So not like hot circumstances, standing up for a long time, seeing blood. These are clear event triggers that are more reassuring. Event triggers that are out with that standard, those standard ones, with no prodrome at all. So people watch it. You go down like a sack of potatoes. That's the typical history. He was running across the road, just fell over in the middle. There was nothing to fall over. When I got to him, he wasn't quite with it. Got him onto the side. Then he was back to normal. Problematic, isn't it? Things that happen during swimming or peak exercise. Swimming is kind of like a double risk, because you're not only are you in peak exercise, you're also supine. And then even if you take out that cardiac risk, events happening in water are worrying anyway, aren't they? So that increases your risk of something else happening regardless of what the causes of the syncopal episode. So things that happen in a swimming pool are concerning. And on the background of a known diagnosis, whether that be congenital heart disease or otherwise. Your risk drops if your history is very consistent with vasovagal syncope, if your ECG is normal or within normal adolescent limits, and I would allow for a little bit of left ventricular hypertrophy with a clearly vasovagal history, if that's the only finding on your ECG that happens in many, many skinny adolescents, and if there's no family history. And in these circumstances, these are the people I want you to reassure, and that further cardiac investigation really is unnecessary, but ECG should be done in all of them, because that also allows you issue to when they come back, have an ECG to refer back to, but also to see if things are changing, right? So we're not going to get it right all the time, but if something is really consistent, but then they come back 2 years later and they've had another event, and then their T waves have started inverting, okay, fine. But we've got the comparative, and we know the ECG was normal the first time, okay? So that will help in the long run if this was going to be something, as well as being reassuring at this moment in time. So going back to our girl, she actually does have arrhythmogenic ventricular cardiomyopathy, difficult diagnosis to make, even difficult for the cardiologist. Most of them go through the cardiac MR scanner. And the reason she is high risk for having a cardiac diagnosis, but actually has got diagnostic features on her ECG of this one, is to do with her inappropriate right axis deviation, which we've seen, to do with her epsilon wave, which is pretty much pathognomic of this if we're sure that that's what it is, and her T wave inversion in V1 to V3, which is abnormal for her age, but it extends, doesn't it, across into V4, V5, and V6, which is normal and suggests that the way her myocytes are repolarizing is abnormal. Okay, what you may also see is ventricular ectopy. There is none on her ECG, but it basically is providing you with a substrate. So an abnormal way of the myocytes repolarizing provides you with a substrate for having ventricular ectopy relatively frequently. So imagine if you put her tape on, she's likely to have quite frequent ectopy if you put a halter on her, but that then provides the substrate for having a ventricular arrhythmia. So in summary, what I hope I have guided you through is some normal ECG features in children woven into those children that have abnormal diagnoses, what features in the history and the ECG raise your risk profile, and have a clear understanding of what syncope is, that it's not all cardiac, but that we were now much more able to find the ones that are. I can send these slides to you actually, but if anyone wants to screenshot that as the references I have, I'll leave it up there for a bit. The first two that are in blue, because they're hyperlinks, but obviously you can't click them, are talking about the very good references from the European Society of Cardiology about syncope, which has got a pediatric section, and then about the interpretation of the neonatal ECG, which is very helpful in terms of risk stratification as well, and worth a read, although ESC guidelines are rarely less than 50 pages long, so be focused and have time. Okay, so all right. Any other questions? I mean, you've heard my voice for a really long time now. Actually, any questions from you? You might have a question for me.
I don't, in fact. That was brilliant. Thank you so much. I just I'm going to take this opportunity though just to remind people there is a link in the chat for feedback, so please complete that. Okay, well look, if there's no other questions, people, look, I'm not that hard to get hold of, but if there were some questions actually that I noted down before. So if we've got 5 minutes, where are they? I have them here. Then I can go back, we'll go back to SVT and just make sure that people that are on this talk feel like they've got their questions answered, because these talks are for you, not for me. So here we are, right. Is that okay actually for 5 minutes to go through the other stuff that came up about SVT? So we talked about, and if people think of a question on the syncope stuff, please tell me, because I actually weirdly like syncope, because it's nice to explain. And also I agreed to give this talk, so I need to answer your questions, right? But I also get a lot of syncope in my clinic, so I have got quite a lot of children falling over all over the place. So please do think of questions and ask them. If I can't answer them, I will try and find someone that can. So what we went through with the SVT, we talked about the diving reflex. I think we talked about vagal maneuvers probably enough. I went through refractory and recurrent, and we went through broad complex tachycardias, and really the best option when it's someone off the street is just to follow the algorithm for APLS. The only reason we talked about SVT with aberrancy is to be honest, in the context of children where you know that their baseline ECG is abnormal, you know that they go into SVT, and then they should really have more of a personalized pathway. So if you know these children exist, we should be asking for management plans, actually, a bit like in seizures, right? You know, personalized management plan. So if we know we've got someone that's going in and out of SVT that could be misdiagnosed as VT, that's where a good plan, you know, like an emergency access plan in ED or on their record is helpful. And I imagine you would know these children if they come in. They are likely to have had previous cardiac surgery. They are likely to be known to the cardiologist because it will have been misdiagnosed in the past. So someone asked a question on
someone asked a question which was around ablation actually, but I think really is a broader a question on what do we do with these children in the long term. And I don't think you necessarily need to know that to be good in emergency, but I think it's helpful because it gives you an idea of where these children are going. I see SVT in my really simplistic way a bit like a seizure. I think you can have one episode of SVT in your life and not have any need for any medications outside of the infancy, right? When children are under 1, we cannot tell when they're going into SVT. Their left ventricular reserve is possibly a little bit less, and they're way more likely to be in it for longer. So their chance of going into cardiac failure is higher. So we treat them. One episode of SVT and you're out in infancy, right? You get some medications, you stay on them till you're 1, we do a tape, we take you off them, and we see what happens. Their outcomes are very, very good, but our ability to diagnose SVT based on their feeding history or whatever else or symptoms is very poor. So if they go into SVT at 6 months old, it's going to take you a long time to recognize it. It's going to take the parents a long time to recognize that they need to come to hospital. And then even in hospital can potentially take time to recognize they're in SVT. And that just massively increases the time that they are in SVT. So on a risk benefit strategy, we treat these children till at least 9 months old, usually with propranolol. Over the age of 1, symptoms, and in children that are neurodevelopmentally normal, symptoms become more easy to describe. That doesn't mean they can necessarily describe palpitations, but if they can describe to you what is happening, parents can understand that that's what they mean. And therefore, a watch and wait approach can be quite effective. So we, for example, have got a 2 or 3-year-old who, I think maybe he was 3 when he first came to us, had an episode of SVT, was cardioverted, following a dose of adenosine in emergency, and then brought back to clinic. All of these children do need an echo. Okay, we're looking for congenital heart disease, and that's undiagnosed, and making sure that their LV function, we've not missed loads of time in SVT and their LV function is not compromised. So they do need an echo, but usually they only need 1 because the majority of these children have got structurally normal hearts and they've got normal LV function. So once they've come back to clinic and had 1 echo, you need to start them on anything in emergency, keep them in monitored for 24 hours or something, they get sent home, and then in clinic we talk to them about beta blockers. On the basis of a first episode, I have rarely started them on a one-off episode that has been short and has been very easy to identify and easy to cardiovert, because actually they may never have another one, and around a third of children don't. So it's worthwhile counselling them around that. If they are absolutely beyond themselves with anxiety, their mum can't cope, etc., etc. These are all the intricacies of medicine that we bring to the actual what we do with that one child. But in general, you don't have to run in with beta blockers. You might have to run in with beta blockers if it has been very difficult to get them out of it, in which case they probably will have started beta blockers in hospital, but nevertheless, or if they are a bit younger, maybe they're 1, they're not talking much, they're 2, something like that. That might be something that gets me over the edge, or they had been in it for a really long time and their symptoms weren't clear. These things make me more likely to do beta blockers. And I think then when you're getting into the realms of more than 1 agent to try and control the number of episodes they're having, they go to the cardiologists, because most of the additional agents that you give, whether that be flecainide, whether that be amiodarone, which is really falling out of favor, have some negative chronotropic impact on the left ventricle. So they then do need monitoring on these agents by someone better than a PEC, let's be honest. So so that's what I would do in terms of where they go. The question came from ablation. Do we ablate these children? So what ablation is for, I don't know what I didn't really read properly what the span of the audience is, but ablation is trying to identify, mapping the heart electrically, which is super techy actually, and very interesting to watch. But they put a catheter inside the heart, they look for electrical activity, they find out where the SA and the AV node is, and then they map where they think all of these things are. And if they find evidence of pathways where they shouldn't be, they can then either with heat or cryoablation or with laser ablate them. So yes, that is done, and the recurrence rate is very low after that actually. However, the smaller the child, the more likely this is to be closer to the AV node. And the problem with something that is being guided at an area in a small child's heart is it's going to ablate more than just what you're aiming at, or you might not be exactly on track. You can't see the electrical conduction pathways, you're mapping them. So there's a risk of heart block. And once you've ablated the AV node, there's no way back from that. Okay, so then they're going to need a pacemaker. So what they tend to do is, unless it is incredibly burdensome, they wait quite a long time on medications until they will go for an EP study. And usually by a long time, I mean 5, 6, 7, older. So they're a bit bigger. And that is because the larger the child gets in terms of physical weight, but obviously that corresponds a little bit to their age, the less likely they are to have complications of specifically that complication. So that's the main complication. It's otherwise quite an easy, I say this not doing the procedure, but apparently quite an easy procedure, which is a day case. So I think the burden on the child and their family to go in and come out is not high, but there is a risk of block or of ablating the wrong thing. But otherwise, in studies that are of children over the age of 5, they've got around a 90% cure rate here. So it's pretty good once they get it pinned down. And that brings me on to one other thing that I thought was worth mentioning is what do we do with children that we find a delta wave, but they've been completely asymptomatic? I know that's not a question that's been asked, but it was a question that was asked of me yesterday. I thought it was really interesting. I have a child in my clinic who's about 13 or something, and she came to A&E with loads and loads of chest pain. She's never had a syncopal episode. She's never had palpitations ever. We've taped her. She's not got anything, but she has got a delta wave very clearly on her ECG. So she's completely asymptomatic. So basically, the answer to that is I don't entirely know what I'm going to do with her, but I suspect she's going to go for an EP study because she's now old enough to be saying, are we beyond the point of waiting for symptoms? Is this now prophylactic treatment? And then that would be a conversation to have with her probably around the age of 15 or 16 about what she wants to do and what the relative risks are of doing that versus we don't have to do anything for symptoms because she doesn't have any. But in principle, someone with a delta wave and a short PR interval, even if they've never had an episode of SVT, they're very likely to have one. And those children are more at risk over the course of their entire life of an SVT at some stage. And it's not high risk, but at some stage deteriorating into a more sinister arrhythmia. So they will get EP studies, but when and exactly when is a bit up for debate. Okay, so are there specific patients or diagnoses, hang on, I just lost that, who had an episode and recovered who we should not send home from ED? Okay, so if you clearly know that there is a diagnosis of hypertrophic cardiomyopathy or long QT syndrome or anything, right, that they have definitely had a syncopal episode and the history sounds like that was a cardiac syncope, they should be monitored for 24 hours if there's clearly an underlying history, especially if it's HOCM. You should be discussing it with a cardiologist because if they've had a syncope in the context of exercise and that's never happened before, that could suggest an increase in their obstructive component of their HOCM, and therefore their left ventricular outflow tract is getting worse. That usually happens over a really, really long period of time, so not usually in childhood. However, they are important children to flag to the cardiologist. So if we've got a diagnosis, I think, yes, as a minimum, some observation, but usually children with cardiomyopathy type diagnoses that are fainting in exercise would need an evaluation by the cardiologist. Sometimes they can do that in some sort of rapid access echo clinic, so they might be okay to go home, but it will need a discussion. ECG changes suggesting that you don't want to send them home. I think that most of them are kind of what I'm alluding to in the talk. If you've got a high risk history plus a load of ECG changes, I would as a minimum want to monitor that child overnight. What you can't do in a lot of places is an echo immediately. You can't immediately get it. You might be able to get a 24-hour tape for them to go home with, maybe. So is there a specific ECG change that I would absolutely keep in? I don't know is the answer to that. I don't know if there's a specific, in a normal sinus rhythm, if I found a ventricular arrhythmia, I'm keeping them in. If I found SVT, I'm keeping them in for 24 hours, usually, unless they're a recurrent attender for adenosine, then they usually are happy to go home. So if we found an arrhythmia, I'm keeping them in. If we found a lot of very high risk cardiac things, am I keeping them in? Probably depends on the context of the situation, but I would make sure that they have very comprehensive follow-up to go to and some good exercise advice, which is usually don't do it until you've had a full evaluation. I hope that sort of answers your question. I don't think there's any one thing that I could put my finger on that would mean in an undiagnosed child, I would definitely keep them. So wondering how to manage SVT in kids with ED with underlying Wolff Parkinson White without adverse features, with medication to avoid and which ones to start. Avoid adenosine, beta blockers, calcium channel blockers. Oh, okay. So that's interesting, because that's not what I would usually work with. If we know that they've got Wolff Parkinson White, they should be due to have an EP study. They are usually higher on the risk list for the cardiologists. But I would be using adenosine in these, and I'm not quite sure why not. So either I'm missing something, or unless if in that case it didn't work very well for them. Usually those children are on beta blockers. So I've got a few children with WPW on beta blockers. Using amiodarone, procainamide we don't use much in this country. It's used more in the States, but using amiodarone is done. I think that amiodarone would not be considered a safe drug by the cardiologists. When we used it in the doses that's suggested in the APLS guidelines, it causes significant problems with the left ventricle. So they're really arrest doses. Don't use that in SVT. If you are considering using amiodarone in SVT, I would get advice from your local cardiac intensive care unit or transport team, because usually they use a smaller amount infused over a 20-minute period. And we've got guidelines with CATS and PANDA. We use, okay, I think PANDA using CATS guidelines for our transport teams, but amiodarone is usually used over a longer period of time. It's not like your arrest dose where you just blast it in, because that can cause significant left ventricular compromise. I still have difficulty differentiating between VT and SVT with aberrancy. Great, so do I, especially if there isn't fusion. Right, so you're talking, what's the best approach? Would you give them amiodarone if they had would it be disastrous? Right, so what is the best approach? I think that's exactly why APLS have created their guidelines in the way they do. I still have difficulty differentiating VT from SVT unless it's really obvious, right? If there's a fusion or a capture beat, then we can be much more clear that it's VT. If it's a bit more chaotic, it's usually VT, but VT can be very regular, okay? And it can not have any of those things on your initial ECG. So I think the point is, it is difficult. And if you don't know this patient from before, so we don't know that this is a child that goes in and out of SVT with aberrancy all the time, and that has been clearly diagnosed, we have to base this on that the child has an arrhythmia. We're no longer in my talk trying to filter out children that are high risk and low. This child is having an arrhythmia. They're my high risk kid. They've done it. They're in. So you've met my high risk criteria because you've gone into an arrhythmia, whatever that is. So then you've already there. So then we need to risk stratify. Is it higher risk to treat this not knowing as SVT with aberrancy, or to go down the VT pathway? And the reason APLS have written their guidelines in the way that they have is because treating it as SVT with aberrancy and being wrong is higher risk. So if you don't know, go with the broad complex tachycardia guideline. I would usually avoid giving them amiodarone, because I think it's because it's usually a last resort. I think that when you've got a child that you know has had cardiac surgery, you know they've been in SVT, or they're very, very stable, you've got time to discuss it, potentially. Some children are really stable with SVT, with aberrancy and with VT. So you do sometimes have more time on your side than it feels internally. So you've got time to discuss it. But I think usually people fall on the side of, 99% of the time they fall on the side of treating it like VT and being wrong and accepting that that's likely because it's safer. Okay. All right, that's way more than your 15 minutes actually, sorry. But I think we've covered everyone's questions.
That was brilliant. Time very well spent. Thank you so much.
All right, and we'd really love for you to fill in the feedback forms for myself and Marwa. We are probably not necessarily absolutely us, but we're probably going to come back and teach you again on a different sort of topic from our hospital. So any feedback that you have on the format, on whether you want totally different things, whether you like there to be a theme, whether about our speaking, will all be used to help us get better and also to help the things that you receive get better.
Brilliant. Well, that's perfect. Thank you so much, everybody, for joining. For those of you that are trust representatives or a part of the committee that want to stay on, feel free to, and we'll have our committee meeting. For those of you that aren't, thanks very much and enjoy the rest of your mornings. Thanks very much, Anna. Thanks very much, Marwa.
Thank you.